Brown, are you ready?
Yes, I am.
Excellent. Welcome, everybody. Welcome to our ACEs Aware Kings County peer-to-peer session. It's nice to have a little chat beforehand and check in with people, see how you're doing at 7 a.m. in the morning. I hope you have your coffee. Let's see, by show of hands, who has had coffee this morning? Show of hands, who's got coffee going? Yeah? Or you could, the hand feature. Who are tea drinkers in the room? Raise your hands if you had tea this morning. I knew it. Yes, Cameron and Lexi. All right, we have got some tea drinkers. Yeah, well, 7 o'clock is early for a Zoom meeting for a lot of people I know. And so I'm glad you're here with whatever beverage you may have, coffee, tea, water, or orange juice, whatever gets you going in the morning. We are going to get you going with a really exciting speaker today. Next slide, please. For those of you that are familiar with Zoom, you know that we've got some housekeeping tips. We are recording this. Karina, if you want to go ahead and hit record anytime as we move forward. If you have any problem with recording, go ahead and keep your camera shut. Otherwise, we love seeing your smiling faces with your camera and your video screen open and awake. So just be aware we are recording. This will be available afterwards. We have it posted on KPFB's website as well as ACES Connection. So if you missed any information, you can absolutely go back and get the recording of this. If you're attending remotely, please be sure your Zoom microphone is on mute. If there is a question during the course of this conversation, we would like to keep this as a dialogue. So you can certainly unmute yourself during the presentation and ask questions, or you can type it in the chat feature. Either way, we will take care of you and your questions. If you have audio issues, join by phone, mute your phone. Make sure your name is typed in the, your name is represented appropriately, because I'm going to be putting that or using that to list yourself out on our raffle prize. And check your name and pronouns. Rename if necessary. Next slide, please. For those of you that have been here before, you know that our grantee collaborators, we have a great team. Can I have a show of hands of our team members who are here? Yeah, we have Erica, Karina, Cameron, Lexi, and Linda. There we go. Excellent. It's good to have our team members here in support of the peer-to-peer work that we're doing. We have the Kings County Health Department represented. We have California Health Collaborative represented, Kings United Way, and Kings Partnership for Prevention, all represented here today. Glad to have them. Our collaboration is strong and has done some amazing work in a short period of 6 months. Next slide, please. Our ACEs Aware mission, we always like to start with, is to change and save lives by helping providers understand the importance of screening for adverse childhood experiences and training providers to respond with trauma-informed care to mitigate the health impacts of toxic stress. And this is important because it is part of Governor Newsom's California for All initiative. Next slide, please. As you see our agenda, pretty straightforward. We're going to be starting in just a moment. I'm a minute over. I'm going to introduce our speaker, and at 7:50 we'll take questions. 8 o'clock, officially our session ends. We're going to be doing a raffle prize, and we do have a presentation at 7:50, right after the questions are done from Kings United Way and 211. So on that note, in case anybody has any questions before we start, I'll give a quick pause here for those questions. Otherwise, I would like to introduce our speaker. Next slide, please. Ladies and gentlemen, welcome to Coffee and Connections, our peer-to-peer event. Really, really, really excited to hear Dr. Monique Brown today. Dr. Monique Brown is the epidemiologist and assistant professor at the Department of Epidemiology and Biostatistics, is a mouthful, in the Arnold School of Public Health at the University of South Carolina. She received her Bachelor of Science degree from Bates College, her Master's of Public Health degree from the Brown University School of Public Health, and her PhD in epidemiology from the Virginia Commonwealth University School of Medicine. Dr. Brown has published several manuscripts on adverse childhood experiences and their link to sexual health, behavioral, and mental health outcomes. Her research in examining childhood sexual trauma and its impact on HIV and aging is funded by the National Institute of Mental Health. Ladies and gentlemen, give Dr. Monique Brown a big round of applause.
Thank you. Thank you so much.
Welcome her, and Dr. Brown, please take it away.
Thank you. Thank you so much for having me today. So I'll be talking about adverse childhood experiences, of course, and understanding behaviors given a trauma-informed perspective, a provider guide. So first I will define adverse childhood experiences, although I know most, if not all of us know the definition. I'll do that briefly. Then I'll present the epidemiology of adverse childhood experiences, or ACEs, in the US and Kings County. And then I'll discuss some research that looks at the link between adverse childhood experiences and behavioral and mental health outcomes. I'll look at intimate partner violence, age at sexual debut, and a wide range of mental health outcomes, including depression, substance use and abuse, and post-traumatic stress disorder. And then I'll also suggest recommendations for providers for screening and connecting patients with intervention programs. So let's look at the definition and epidemiology of adverse childhood experiences. So as we know, ACEs are traumatic events that take place during childhood. And I like to think of them as either being direct or environmental. So when we think about direct ACEs, we think about abuse, whether that's sexual, physical, psychological, or even neglect. And when we think about events that happen in the environment of a child, we think about the child perhaps witnessing domestic violence, substance misuse, so living with someone who has substance abuse issues, living with someone who might have mental health challenges, divorce and separation of parents, living with someone who had been incarcerated, as well as some research has begun to talk about even parental death as an adverse childhood event that can occur. But it's also important that we think about expanded adverse childhood experiences definitions when we look at community level adversity. So when we think about witnessing violence, we can think about that as an adverse childhood event as well, witnessing violence in the community. When we can also think about feeling discriminated against, whether that's because of race or ethnicity, or even because of sexual orientation. We can think about feeling safe in the neighborhood. So if there was an adverse neighborhood experience, feeling safe, or if they felt people in the neighborhood looked out for each other. Bullying, which has been a huge component of what we think about when we think about children going through adverse events. So bullying can be another adverse childhood event that we can think about, and even being in foster care. So having sort of that, in certain cases, instability can also be an adverse childhood event. So we have these direct and environmental ACEs, but we also have these neighborhood level or community level adversity experiences that we can think about when we think about adverse childhood experiences. So how common are ACEs? And this is data from the Centers for Disease Control and Prevention from the CDC, and it shows that ACEs are relatively common. So here we show that approximately 62% of people have experienced at least one adverse childhood event. So 24% experienced 1, 13% experienced 2, 9% experienced 3, and 16% experienced 4 or more. So that gives us around 62% experiencing at least 1. So it's relatively common when we look at the US estimates. And then when we think about prevalence of ACEs by categories, we see that 34% of people who were exposed to ACEs reported emotional abuse, 18% reported physical, 12% reported sexual abuse. And when we think about witnessing intimate partner violence, 18% of children reported experiencing witnessing intimate partner violence in the home. 28% lived with someone who had a substance abuse issue. 17% lived with someone who had a mental health challenge, and 28% had reported their parents being separated or divorced. 8% reported living with someone who had been incarcerated at some point. And then when we look at epidemiology again of adverse childhood experiences in the US, this was data from 2019. This was data I was able to analyze. So we see that 44% reported no ACEs, but we see that 22% reported 1, 12% reported 2, 8% reported 3, and 14% reported 4 or more. So we see that ACEs are still, even with the most recent data that we have, are still relatively common. And then this table shows us number of ACEs in Kings County and California. And we see that ACEs are common among households with children. And when we see households without children, we're talking about a retrospective look at adverse childhood events that could have occurred. So we see that when we compare ACEs in Kings County to California, the numbers are a little bit higher, especially when we look at number of ACEs 4 or more. We see that households with children in Kings County, 20% reported 4 or more ACEs, while in California, 17% reported 4 or more ACEs. And we see a similar trend for households without children and all households. So we see that ACEs in Kings County are a little bit more common than when we look at California overall. Okay, so now we're going to just delve into a little bit of the research into what are the links between adverse childhood experiences and behaviors. What does the research tell us? And so we know that early adversity has lasting impacts, and this was taken from the CDC. And we can see that adverse childhood experiences can lead to injury. When we think about traumatic brain injury, it can also lead to mental health, adverse mental health outcomes such as depression, PTSD. Adverse childhood experiences can impact maternal health, unintended pregnancy, pregnancy complications. They can also lead to infectious disease, and we'll talk about that a little bit later, leading to HIV or STIs. It's also linked to chronic disease such as cancer and diabetes, risky behaviors such as unsafe sex, alcohol and drug abuse, and also even opportunities with linking to lesser or less education, occupation, and income opportunities. So for this presentation, we're going to focus on mental health, infectious disease, and risky behaviors. So one of the projects that I was able to complete as part of my dissertation work, for my dissertation work, I looked at adverse childhood experiences and behavioral outcomes and mental health outcomes. So this paper was published in Social Science and Medicine, where we examined adverse childhood experiences and intimate partner violence perpetration or intimate partner aggression in the US. And we looked at the differences and similarities by sex in psychosocial mediation. And I'm going to go into that a little bit so we can have a better idea of what was done. So when we think about intimate partner violence perpetration, so, people who are perpetrating violence against intimate partners, we can think about the clinical approach to the interpersonal model, which has 4 theories which help us to understand IPV perpetration. So we can think about social learning or family of origin, cognitive behavioral theory, personality theory, and clinical theory. And these theories explain intimate partner violence perpetration via psychological disorders. So saying that perpetrators may be more likely to have greater levels of psychopathology. So those who perpetrate intimate partner violence may be more likely to have PTSD, substance abuse, and depression. So the rationale for this study was that we have observed sex differences in intimate partner violence perpetration. So severe physical perpetration was more strongly associated with fewer social support resources and depression symptoms among men compared to women. And we have seen sex differences in the association between adverse childhood events and intimate partner violence perpetration. However, research examining the role of mental health in the association between adverse childhood experiences and perpetrating intimate partner violence, that research was lacking. So we wanted to look at, and this is just the model, this shows the model that we examined with the research question. So here we have neglect, we have physical, psychological abuse, sexual abuse, parental violence or witnessing parental violence, or living with someone who had been incarcerated or had mental health, adverse mental health outcomes. And then here we have the mental health outcomes such as PTSD, depression, substance abuse, and then that being linked to perpetrating intimate partner violence. So this is the model that we were interested in looking at. So what did we find? So this shows the results that we found among men. So we saw that physical and psychological abuse was linked to PTSD, depression, and substance abuse among men. Sexual abuse in childhood as an adverse childhood event was linked to PTSD and depression. Parental violence, witnessing parental violence was linked to intimate partner violence perpetration, and incarceration or psychopathology. So living with someone with these factors was linked to IPV perpetration and PTSD. And the results were a little bit different for women, where we saw that physical and psychological abuse was linked to PTSD, depression, and substance abuse, and witnessing parental violence was linked to depression, and parental incarceration or psychopathology was linked to substance abuse. So we see that there were some differences when we looked at men versus women. So when we looked at the role of mental health, so these were the links that we saw. So we see that for men, sexual abuse was linked to PTSD, which was linked to IPV perpetration. Physical or psychological abuse was linked to substance abuse, to IPV perpetration. And then for women, we see that physical or psychological abuse during childhood was also linked to substance abuse in adulthood, which was linked to IPV perpetration. So those were the main findings of that study. So the next study that we looked at examine adverse childhood experiences and early age at sexual debut in the US. And we wanted to look at the disparities by gender and also by sexual orientation. So when we look at the scientific literature, we see that ACEs are associated with sexual debut in early adolescence, right? So sexual abuse and physical abuse has been linked with sexual debut, early sexual debut, exposure to adverse childhood events, and subsequent sexual risk behaviors may actually represent attempts to obtain close interpersonal connections. And early age at sexual debut has been linked to a wide range of adverse outcomes, such as multiple unintended pregnancies, inconsistent contraceptive use, multiple sexual partners, alcohol or drug use at sexual intercourse, sexual violence, and intimate partner violence. So we wanted to look at the association between neglect, sexual abuse, physical, psychological abuse, parental violence, and incarceration psychopathology. We wanted to look at these adverse childhood events and age at sexual debut, but we also wanted to look at the gender and sexual orientation differences and if there were differences that existed by these factors. So what we found that all adverse childhood events were positively linked to earlier age at sexual debut, but we saw differences in the point estimates for men and women. So for example, if we looked at sexual abuse, we see that for men, so this point estimate is telling us that men were about 10 times more likely to have early age at sexual debut at less than 13 if they experienced sexual abuse as a child. And we saw the point estimate was even much higher for women, where it was around 90 times. Women were 90 times more likely to have early age at sexual debut if they experienced sexual abuse during childhood. And these were the estimates. We saw that the estimates were a little bit stronger for women compared to men, depending on the adverse childhood event that we examined. And then we saw that there were also differences in point estimates when we examined sexual orientation. So we looked at heterosexual populations, populations that identified as bisexual, populations that identified as men who have sex with men, or women who had sex with women. And when we look at witnessing parental violence, for example, that was linked to early age at sexual debut. So heterosexual point estimate was around 4 times, bisexual was over 200 times, MSM was 13 times, women who have sex with women were 60 times. So these point estimates are telling us that those who witnessed parental violence, they had a higher odds of having an earlier age at sexual debut. So having an age at sexual debut of 14 years old or less. So these are telling us that ACEs were definitely linked to earlier age at sexual debut. And then now we're going to look at what the research says about adverse childhood experiences and infectious disease. So this paper was published in AIDS and Behavior. So we wanted to look at the gender disparities in adverse childhood experiences and HIV STIs. So one model that helps us to understand, and when we think about research questions, we try to think about at times if there's a specific model or theoretical framework that can help us to understand the research question. So when we think about the traumagenic dynamics model, this offers a viable framework to investigate sexual health consequences associated with childhood sexual trauma. And there are 4 traumagenic dynamic factors. So traumatic sexualization, betrayal, powerlessness, and stigmatization, which can help us to understand that association. But when we think about adverse childhood experiences overall, we recognize that the three latter factors in this model, betrayal, powerlessness, stigmatization, these can maybe help us to understand the association between adverse childhood experiences, so not only sexual trauma, but adverse childhood experiences on a whole and sexual health consequences later on in life. So we wanted to look at adverse childhood experiences and a diagnosis of HIV or STIs. So this was the model that we looked at. Once again, adverse childhood experiences on your left here. In the middle, we wanted to look at mental health outcomes such as PTSD, depression, substance abuse, and we also wanted to look at early sexual debut and intimate partner violence perpetration to see the roles, if they played a role in the association between ACEs and HIV STIs. So this diagram shows the findings among men. So basically neglect, physical, psychological abuse, sexual abuse, parental incarceration, psychopathology, these were linked to the mediators that we looked at, so the mental health outcomes and the behavioral outcomes, and then these were also linked to HIV, STI. So these mental health outcomes actually played a role in the association between adverse childhood experiences and HIV, STIs among men. And when we look at women, the results were a little bit different, where we see that these were the ACEs that played a significant role in the association with HIV, STIs. And looking at major depression was very important, substance abuse was very important, and having early sexual debut was also an important factor in adverse childhood experiences and HIV, STIs. So we went through a lot of research. So basically we have seen that adverse childhood experiences have been linked to early age at sexual debut, HIV, STIs, and we think about these mental health outcomes such as depression, PTSD, substance abuse disorders. So we see that ACEs definitely have a role to play in these adverse mental health and behavioral outcomes. And we also looked at intimate partner violence perpetration. So what are some of the provider recommendations based on these findings? So it's very important to screen for adverse childhood experiences. So we have the ACE questionnaire, and these questionnaires are usually they have, well, this one specifically has 10 categories of adverse childhood experiences, and then you can screen for if they live with anyone with mental health challenges, or if they lived with anyone who was incarcerated, if they experienced sexual abuse, neglect. So this ACE questionnaire really covers a wide range of adverse childhood experiences. Unfortunately, this questionnaire does not cover the neighborhood adversity that we talked about previously, but that's something that also can be considered when screening for ACEs. But this questionnaire has been used widely. And it's also important to screen for depression. So there is the Patient Health Questionnaire 2, which has 2 items, which it's a 2-item measure that can really screen for depressive symptoms. And then if the person scores positive on this item, then you would go to the Patient Health Questionnaire 9-item measure, which goes a little bit more in depth about things that have been bothering the patient over the past 2 weeks. And so you can think about if they had little interest or pleasure, if they're feeling down, if they have trouble staying asleep, etc. So we have the patient health questionnaire 2, which is very easy to administer. It's just 2 items. And then if the score is 3 or greater, then we turn to the patient health questionnaire 9-item measure. So it's very important to screen for depression as well. Screening for PTSD is also important. There is a 5-item primary care PTSD screen. And here you're basically asked if you've experienced a traumatic event and if that event currently, if you're having challenges dealing with that event. So if you've had nightmares, if you've tried hard not to think about the event, if you're constantly on guard, if you felt numb or detached, if you feel guilty about the event, etc. So this tends to be used in primary care and can be used to screen for PTSD with 5 items. And then there is the substance abuse screener called TAPS. And basically, this is a screener for in the past 12 months if you've used tobacco or any other nicotine delivery product. It also assesses binge drinking for men or for women, prescription medication, if you took prescription medication more than prescribed or that were not prescribed for you, and if you've used any other drugs such as marijuana, cocaine, heroin, etc. And then the response options are daily or almost daily, weekly, monthly, less than monthly, never. So this is a way in which you can also screen for substance abuse. So also not only screening for these adverse health outcomes or behavioral outcomes, but also providers can consider referral to specific programs. So the strongest evidence that we've had for abuse-related ACEs has been cognitive behavioral therapy. So this has been shown to improve mental health outcomes for those who experienced abuse and or neglect. So that's the strongest evidence we have for, so referral to a program that focuses on CBT would be recommended. There are also other psychological therapies, but there have been mixed findings, such as brief motivational interviewing, family therapy, and psychodynamic therapy. Those have been evaluated, but there have been some mixed findings. There are also psychoeducational programs, and effectiveness has been shown for mental health outcomes in children of parents with depression. So remember, even if you're living with someone with a mental health challenge or mental health outcome, that the children can be affected as well. So there are programs that have shown to be effective to improve mental health outcomes in the children of parents with depression. And then other programs such as parent or foster carer training. Most studies have focused on behavioral challenges. The findings for these trainings are also mixed. There's also cross-sector support or wraparound support. The wraparound term is used to describe individually designed set of services and supports for high-risk children and adolescents with the most complex needs. So findings are mixed, but there are some positive results in terms of having wraparound support or case management. There are also educational interventions that are school-based and housing and life skills interventions. So having support services for people transitioning out of care are effective for housing and independent living outcomes. So these are some of the programs that providers can think about when they're thinking about screening for ACEs or thinking about trying to recommend programs for people who have been affected by adverse childhood events. And so in conclusion, as we have seen, ACEs continue to be a major public health challenge nationally, and also it's also a global public health challenge as well, but we focused on the national statistics. We focused on a little bit on Kings County and California. And it's also important that we consider the expanded definition of adverse childhood events. So considering the neighborhood level adversity, the bullying, the discrimination due to race or ethnicity, the discrimination due to sexual orientation, the neighborhood feeling safe. These are adverse childhood events that we should also think about as we go about caring for others. And as we have seen, ACEs have been linked to behavioral and mental health outcomes. The links are complex, but we see that mental health outcomes definitely play a role in the association between adverse childhood events and adverse behavioral outcomes. And providers should consider screening for ACEs and mental health outcomes and referring patients to programs such as cognitive behavioral therapy. And I think, yes, and I think that was it.
Thank you so much, Dr. Brown. That was excellent. Very, very, very informative information. Really appreciate you taking the time on that. I had a question with regard to the screening. If a primary care provider is using the ACE screening tool, what would be a trigger to then go ahead and utilize the other screening tools, the depression screening tool, the substance use screening tool? I mean, there's a lot of screening tools that you discussed. What would prompt a primary care provider to use the additional screening tools once they've done the ACE screening tool?
So that's a very good question. So I think what would be a trigger is if, for example, even I think when you screen for ACEs, I think it's also important that maybe doing the patient health questionnaire too. So just screening for depression, depressive symptoms. So screening for depressive symptoms, and then that could be a more of a trigger to then focus on the PHQ-9 or the PTSD screener. So I think the ACEs, so with the ACEs, we can tell if the person had been exposed to certain adverse childhood events, but I also think it's important that we screen for the depressive symptoms as well in sort of in alignment with screening for ACEs.
And does that come out in conversation after the screening tool? How would you go about assessing that need verbally with the patient?
Sorry, could you repeat that?
Sure. Does that come out, the information, does that come out in a conversation with regard after you take the screening tool? This is in response to the additional screening tools.
Yes, so definitely. So after screening for ACEs and depression, and then if it's apparent that there are depressive symptoms, then you could also screen for PTSD, and this would come out in conversation with your primary care provider or with the patient. So then you can screen for these other adverse health outcomes.
Wonderful, thank you. Thank you. We have another question from Teresa Alvarado. She states, these reports must have taken years. When did your body of study start?
Okay, great. So I started looking at adverse childhood experiences as an area of research. I think it was around 2000 and maybe 2011, 2012. And then I started to do work. So one of the first studies that I did when I was during my PhD program at Virginia Commonwealth, I looked at adverse childhood experiences and cancer. So I recognized that there was actually a link between adverse childhood experiences. There was an association between adverse childhood experiences and cancer. So based on that, I wanted to do more in terms of finding out, okay, what are these other behavioral or mental health outcomes that may be associated with ACEs. So I started around 2011, 2012, and then my dissertation project ended in 2014. So it took around 3 to 4 years. These are secondary data analyses. So thankfully the data had already been collected. So I was able to do the analyses and so forth within that time.
Excellent, thank you.
Thank
Very
you.
much. Do we have any additional questions? Either you can put them in the chat box or you can unmute yourself. I encourage you to unmute yourself and ask those questions as we have this time now available.
Well, Dr. Brown, I was the person who asked the question about how long it had taken, just because the presentation that you made today was so comprehensive. So we appreciate the work and genuinely the love of the topic that you want to bring forward with your results. So thank you very much.
Thank you so much. I appreciate that. You know, this is something that's really dear to me because I know this is, you know, adverse childhood experiences, as we have seen, are common events, and it's just very important to find out their impacts on our lives, and you know, and the ways in which we can try to prevent them from occurring, or if they have occurred, how can we deal with the consequences that may result. So thank you so much.
Dr. Brown, this is Patty Haver. Thank you so much for just a wonderful presentation and sharing your data. When you look at the prevalence of ACEs between 2011 and 2014, 16% of those surveyed had 4 or more ACEs score. And yet when you show the data in 2019, I see some improvement, lowering of numbers, et cetera. So what may be some of the factors that contributed to the lowering of the percentages between 2011, 14 and 2019?
Yes, that's a great question. So in terms of the lowering of the numbers that we see, it could have been due to, it was because those have been data collected from the Centers for Disease Control and Prevention. So it could be based because it's a different population. So the population that we collected data from earlier, they probably had a higher adverse childhood, a higher prevalence of adverse childhood experiences compared to the data in 2019. But because I think, and also I think there is more awareness now that on adverse childhood experiences as something that we should consider. So it would be interesting to see if this trend, if it continues to decrease, or if it goes back up. So I think that will be interesting to see. But we had 2 separate populations, but it would be interesting to see the trends.
And my last question, and you show the data for Kings County versus California. There are certain unique aspects to Central California, and that is the migrant farm workers.
Okay.
And so I was curious to where the resources for the data, because it would be interesting to look at other counties within Central
Yes.
California, et cetera. So I'm curious, where's the source where we can look up the prevalence by county?
Yes.
But I'm very interested within the subpopulation of migrant farmers.
Okay, great.
Farm
Yes.
workers.
Okay, great. That's great information to know. So the source, I can actually share that with you. I think Linda was the one who sent me the link. So maybe that's something she can share
Yes.
with
Yeah,
people
I
in
have,
the chat.
to support your question, Dr. Patty and Dr. Brown, thank you so much. I have included it in the chat. It's collected from kids' data.
Thank you.
Thank you, Linda.
Okay, unless we have any other questions, we're going to move on to our secondary presentation about referrals from 2 Kings United Way and 211. Any other questions at this point? And Rocio, would you be willing to unmute yourself? I see that you typed something in the chat box about your experience with the screening tool. Would you want to share that?
Mhm.
Yeah, good morning, everybody. This has been my concern. I mean, I think doing this kind of line of work and working with, you know, clients and screening them. Most of the time we end up filling all the paperwork, all the screening tools prior to seeing the doctor or the provider, but there is no further discussion. I think that not unless I pose the question or I ask a couple of things of what the process is, they're really not willing to go forward and actually give that time to have some discussion. And so I wonder, and my concern is, how would that be for those patients that maybe do have a high ACEs, or they are depressed and really do not express that in the screening tools.
Mm.
I mean, I just wonder how, you know, that looks like, because, you know, it happens all the time. You know, people may be thinking in their mind, like, all right, have you been depressed the last 2 weeks? Yeah, but they say no, right? And so how, you know, how can we continue to close that gap, and enriching that communication from patient to provider?
Yeah, that's a great question, and that's a great concern, because if we don't have that communication line open, then these screening tools, as you stated, they won't work. And so I think we need to well, first of all, in terms of the patient, if the patient is willing to express that, you know, they have, you know, undergone these adverse events, it's still affecting them in terms of their depression, in terms of maybe having PTSD, then that is a first step. And I think that once we're able to raise more awareness on, especially among healthcare providers as well, especially among physicians, or, you know, the physician team, the healthcare team, and be able to provide, to raise awareness and to provide even training in terms of ACEs screening and how to move forward from there. So I think once the patient is willing to, you know, talk about their ACEs and their depression, then we have to do our part in training providers so that they can know, okay, what are the next steps that we can take if somebody has been exposed to these adverse childhood events and it's still bothering them to this day. And sometimes, you know, and that's another thing too, sometimes if you don't have, sometimes we don't think that there's a link, like between things that happened a few years ago and, you know, our health now. But I think the research has shown that there is some association between adverse childhood events and our current health. So I think raising awareness among providers and also among patients in general, so that they will know that these screening tools are important in order to improve health outcomes.
Thank you, Dr. Brown. I'd ask everybody to unmute yourself and give Dr. Brown a round of applause. We thank you very much,
so
Dr.
much.
Brown. Excellent. I encourage you all to stick around just a few more minutes. We have a short presentation about referrals directly related to some of the information that Dr. Brown has given us. After the referrals, we've got a raffle prize for if you have attended today. We have a gift card from Starbucks. So stick around to see if you have won the raffle prize. All right, Erica, I'd like to turn this over to you. I'm going to go ahead and share the screen.
So I'll stop sharing.
Yes, please.
Okay.
And there we go. Oops. Let's see if I can. Erica, why don't you go ahead and take it away?
Thank you, George. And thank you, Dr. Brown. That was a great presentation. So good morning. My name is Erica Lopez. I am the 211 coordinator at Kings United Way. So in these efforts, our executive director, who is also included in these efforts, is Nanette Villarreal, and we also have Alexis Terrell, community engagement manager, who is overseeing a new project called the Community Information Exchange, and you'll hear a little bit more about that in just a few minutes. So if we can go to the next slide, please.
Okay. Erica, I'm just wondering, can you see the screen?
Yes, I can see it. Thank you.
Excellent.
Okay, so 211 Kings County allows you to access information on our database on community resources such as food, education services, mental health services, and much more. Just a reminder, 211 Kings County can be reached 24/7, anytime, day or night, and that does include holidays. Next slide, please. So just a quick overview, as mentioned in previous sessions in Kings County, you can access 211 5 different ways. Dialing 211 links callers to a call specialist who directs them to resources. Resource information can be given over the phone as well as texted over to the caller. And if caller agrees to a follow-up, my 211 Kings County team follows up with the caller to see if the caller was able to connect to the resources or agencies, and also provide additional resources if needed. We also have live chat available on our website, 211kingscounty.org. You can also search for resources through our search by text or categories that I'll be going a little over in the next slide. And then we also have the 211 and Telephone mobile app that is available in both English and in Spanish as well. Next slide, please. So, for example, let's say you have a patient that is in need of substance abuse resources. For substance abuse resources, you can visit 211kingscounty.org, click on addictions, and get a wide range of resources that can help support your patient, such as counseling resources, support groups, treatment services, and much more. So 211 Kings County is a great resource to find a resource that you can provide to your patient. So on today's session, there was a few different topics covered. I wanted to take this time and highlight a few that were mentioned. So like HIV testing and early pregnancy support, we do have subcategories that can guide you to that local information. So for HIV testing, you can find that in our health tab. You can also find local resources on pregnancy counseling in our family category. So please keep in mind that you can print resource information directly from our website. Information you will receive on resources are description of a service, website link, phone numbers, location, hours of operation, as well as coverage area and program delivery. For the program delivery, we have information that is regarding like documents required and program fees and much more. You can also provide 211 handouts to a patient and have them access 211 Kings County for local resources if you like as well. Next slide, please. So if you're interested in supplying cards to your patients, please let me know. We have 211 Kings County brochures available in both English and in Spanish. My contact information will be listed in the chat box. But just a reminder, 211 aims to bring organizations in the community together to better serve our residents of Kings County. So organizations providing resources and services are able to provide information to us to add to the 211 database to better serve clients in need of resources. We want to make sure that your voice is heard and for all of our 211 platforms to be able to be easy accessible. So if you have any ideas or suggestions, please reach out to me. We invite you to provide resource information you think would be great for the database. At this time, I'm going to go ahead and turn it over to Lexi to give you information regarding the Community Information Exchange.
Thank you, Erica. Good morning, everyone. My name is Lexi Terrell. I am the Community Engagement Manager for Kings United Way. 211 is an amazing resource and is something that many of you have probably used for your clients or yourselves as a self-help resource. The CIE and Community Information Exchange platform will be a supplement to the efforts of 211 by becoming a database for providers that enables you to send referrals to other organizations on the platform for your client to get connected to appropriate resources such as mental health, food, physical health, and other needed services. Built-in screeners, including the ACE screeners for both children and adults, and the ability to download reports from the CIE make it a versatile tool to support our organizations and our community. Next slide, please. So there are 4 components that create the CIE and the community care plan. So the network partners, which would be all of you when you join, the shared language talking about the social determinants of health and individual longitudinal records, the resource database and bidirectional referrals make it quick and easy to send and receive client referrals and their information. And finally, the Unite Us platform and the possible data integrations with other systems. Next slide, please. So as we talked about, the Community Information Exchange, or CIE, will help link patients and their families to needed services. The Unite Us platform will accomplish this by having a resource database that helps you find information on participating agencies and enables you to start closed-loop referrals. The closed-loop referrals are sent or either fulfilled or returned back to the originating organization if the program is either full or is no longer funded, and email notifications make sure that no clients fall through the cracks of care, knowing that we all have busy schedules. And the sharing client level data protects the client from having to tell their story more than once. And any changes to the contact or content of the client data is automatically updated platform-wide. Next slide, please. So Unite Us hosts information sessions that you can learn more about the Unite Us technology platform. The presentations cover how you can use the platform, as well as how your organization can join, which most of you can for free. If the dates and times don't work for you, please reach out to myself or Kendra from Unite Us to schedule a session that works for you and your organization. Thank you for your time. If you have any questions or need more information about the CIE, or 211 Kings County, please reach out to Kendra, myself, or Erica. I'll provide the links in the chat box. Thank you.
Excellent. Thank you, Lexi, and thank you, Erica. I appreciate the information about 211 and the Unite Us platform. A couple quick announcements before we go to our final raffle prize winner. I want to make sure that you all have the save the date for our upcoming peer-to-peer sessions. We have our next one in April, Friday, April 9th. Again, that's from 7 to 10 a.m. May 14th, Friday, May 14th, and Friday, June 11th. All of these are Fridays. They are from 7 to 10 a.m. And we are going to get you out of here on time today. So make sure you have those dates down, and we look forward to seeing you at our next one. I'd like to let you know that next Friday at 10 a.m. we have our very first ACEs Aware King's Collaboration, Adverse Childhood Experiences and Toxic Stress 101. Our supplemental training is going to be rolled out on March 19th. As I had mentioned earlier, this training has been approved by Aurora Health, ACEs Aware, and Dr. Nadine Burke-Harris herself. So we are excited to get this information out there and build on the education that we have been working on here in the Central Valley. If you are interested, please type your name in the chat if we can send you information, and you can also contact me at my email, which will be in the chat, gyagetik@healthcollaborative.org. That's on the flyer itself. Next Friday is our very first one. I'm excited about rolling this out. I'm excited about getting this information out to the community. Today we have an evaluation survey we'd like you to take. Love for you to give your input on how today went, on how the session was for you today. And if you could take just a few minutes, it goes very quickly, less than 5 minutes to fill out the survey, we would appreciate it. And if you could put that in the chat feature, we would appreciate it. Finally, we have our raffle. All right, for those of you that are here, I am going to go ahead and give this a spin and see who our winner is. And
that's so cute.
I know, right? It's called the Wheel of Names. It's online, and you can actually get this yourself. Carrie Hang. Carrie, who is new to our peer-to-peer session, is our winner for today. And Carrie, congratulations. You have a gift card to Starbucks that we will be emailing you. For those of you that are left, it is 8:08 and we are right on time to finish before 8:10. I want to thank you for joining us today. I want to thank Dr. Monique Brown for presenting. Again, that was an excellent speech, excellent presentation, and it was very informative. So thank you for attending today's peer-to-peer session. Join us next month and we will be closing up. Have a great week and a great weekend, everybody. We look forward to seeing you soon.
Thank you.
Bye.